General principles: patients on chronic anticoagulation for AF, VDE, or mechanical heart valves often need to undergo procedures that pose risk of bleeding. The indication for anticoagulation and risk of interruption must be weighed against the risk of bleeding of the procedure, including possible neuraxial anesthesia. Treatment recommended management varies according to the indication for anticoagulation, medication used, and surgical bleeding risk. For patients being treated with vitamin K antagonists (VKA) such as warfarin, low bleeding risk procedures permit continuation of oral anticoagulation through the perioperative period, e.g., minor dental and dermatologic procedures, cataract extraction, endoscopy without biopsy, arthrocentesis, pacemaker and implantable cardioverter defibrillator (ICD) placement lead to less hematoma if anticoagulation is not interrupted. 31 Significant bleeding risk procedures require the anticoagulation to be discontinued. Although the international normalized ratio I/R at which surgery can be safely performed is subjective, an I/R of less than 1.5 is typically a reasonable goal. The VKA will typically need to be stopped 5 days preoperatively. The I/R should be checked the day before surgery. If a level less than 1.5 is not obtained, 1 to 2.5 mg oral vitamin K effectively achieves an I/R less than 1.5 on the day of surgery. The VKA can generally be resumed 12 to 24 hours postoperatively if postoperative bleeding has been controlled. 32 High bleeding risk procedures, e.g., intracranial or spinal with potential catastrophic outcomes because of bleeding, will preclude any anticoagulation in the perioperative period. Resumption of anticoagulation should be delayed at least 48 hours for other procedures with high bleeding risk, e.g., sessile polypectomy, bowel resection, kidney, liver, or spleen biopsy, extensive orthopedic or plastic surgery. Bridging therapy refers to the administration of an alternative anticoagulation during the time the I/R is anticipated to be below the therapeutic range. The potential decrease in thrombosis must be weighed against the increased risk of bleeding. 33 High thrombotic risk patients with the following conditions should typically be treated with bridging therapy: mechanical mitral valve, older generation mechanical valve, e.g., Starr-Edwards ball and cage valve, any mechanical valve with a history of cardioembolism within the preceding 6 months, non-valvular AF with either a history of embolism in the last 3 months or CHADS to https://trunktam2oc.com/score = 5 valvular AF recent VDE less than 3 months, known thrombophilic state, e.g., protein C deficiency or moderate thrombotic risk patients as below. Bridging may be considered in patients with low bleeding risk. DVD prophylaxis dosing is acceptable. Mechanical aortic valve bileaflet with one or more associated risk factors: AF, CHF, hypertension, age = 75 years, diabetes mellitus, and prior CV aortic history of VDE within preceding 3 to 12 months. Non-high-risk thrombophilia, e.g., heterozygous factor V Leiden mutation, history of recurrent VDE, active malignancy. Low thrombotic risk patients are not believed to require bridging therapy. Treatment with DVD prophylaxis doses of LMWH or UFH is an alternative. This group includes patients with mechanical aortic valve bileaflet without associated risk factors, as above: AF with a CHADS to or less than 4, or history of prior embolism 30 for prior VDE greater than 12 months prior without history of recurrent VDE or known hypercoagulable state. Choices for bridging therapy are generally the LMWHs and UFH, including patients with mechanical heart valves. 31 There is less experience in this setting with other agents, e.g., fondaparinux and their use cannot be considered routine. LMWHs have the advantages of relatively predictable pharmacokinetics and ability to be administered SC. Monitoring of anticoagulant effect is typically not required. Renal dosing is available for patients not on dialysis. Subcutaneous administration allows for outpatient therapy in appropriate patients. This decreases the length and cost of hospitalization. The last dose should be given 24 hours prior to surgery. UFH is the agent of choice for patients with end-stage renal disease ESRD. It is typically administered IV and requires frequent monitoring of the activated partial thromboplast in time. UFH should be stopped at least 4 hours prior to the planned surgical procedure to allow the anticoagulant effect to wane. Fixed-dose subcutaneous UFH has been proven efficacious for treatment of VTE and may be considered as an option. 35 Direct oral anticoagulants have relatively short half-lives. Dabigatran equals 14 hours, rivaroxaban equals 9 hours, apixaban equals 12 hours, obviating the need for bridging anticoagulation. Agents should be held for 2 or 3 half-lives for low bleed risk procedures and 3 or 4 half-lives for high bleed risk procedures, keeping in mind the effects of renal function on clearance. https://trunctam2oc.com/reversal agents may be used if urgent surgery is required before the washout period. Irucizumab reverses dabigatran, and andexanet alpha reverses all XA inhibitors. Patients being treated with antiplatelet agents continuing antiplatelet therapy perioperatively carry the risk of bleeding, whereas discontinuation may increase cardiovascular events. Irreversible agents must be withheld for 5 to 7 days before effects fully abate. Clinicians are again left with little evidence and sometimes conflicting guidelines. Low bleeding risk procedures, e.g., minor dermatologic or dental procedures, allow continuation of aspirin acetylsalicylic acid ASA being given for secondary prevention of cardiovascular disease. Non-cardiac surgery patients should generally have clopidogrel or other phenylpyridines held 5 days preoperatively. Prompt reinitiation with a loading dose of 300 mg should take place postoperatively. Further stratification drives decisions regarding ASA, moderate to high cardiac risk, in which case ASA should be continued perioperatively. Lower cardiac risk, in which case ASA should be held 7 days preoperatively. Coronary artery bypass graft candidates should generally continue ASA perioperatively and have clopidogrel held 5 days preoperatively. Coronary stents pose a particular risk of in-stent thrombosis and infarction if dual antiplatelet therapy is prematurely withheld. Whenever possible, surgery should be deferred until a minimum period of dual antiplatelet therapy is completed. Balloon angioplasty without stent, 14 days. Drug-eluting stents, 6 months. Bare metal stents, 30 days. Urgent surgeries within the previous time frames should proceed with continued dual antiplatelet treatment, if possible. If the bleeding risk is felt to be high, ASA alone should be continued. Heparin bridging has not been shown to be of benefit. Bridging with IV glycoprotein IIV/3A antagonists or reversible oral agents, e.g., ticagrelor, is not routinely recommended.